সম্মানিত চিকিৎসকগণ ও মেডিকেল শিক্ষার্থীবৃন্দ, আজকে সেশনটি কন্ডাক্ট করবে অ্যাসিস্ট্যান্ট প্রফেসর ডক্টর লাইলা শারমিন ম্যাডাম। ম্যাম অত্যন্ত ব্যস্ত সময়ের মধ্যে আমাদের একটু সময় দিচ্ছে, তাই আমরা কৃতজ্ঞ। তাই আসুন দেরি না করে পেডিয়াট্রিক্স এর ইম্পর্টেন্ট টপিক অ্যাকিউট ব্রঙ্কিওলাইটিস এর ক্লাসটি শুরু করা যায়। ম্যাডাম আপনি শুরু করেন ম্যাডাম। আসসালামু আলাইকুম ম্যাডাম।
Walaikum assalam. Thank you for the nice introduction. So today we are going to discuss about a very common condition in pediatric practice, that is acute bronchiolitis. Let's start with a little bit of anatomical background knowledge. So this is the airway, which starts from the nose, and it includes nose, nasopharynx, then down to the trachea, which bifurcates into right and left bronchi. And then the bronchi again bifurcates into bronchial tree, and ultimately it reaches into the small airway, that is bronchioles. And bronchiolitis is the inflammation of this small airway. So hence the name is bronchiolitis. And it is caused by mostly viral infection. Commonest one is the respiratory syncytial virus. And as you know, as you see that the route of entry is from the upper respiratory tract. So the disease starts with the symptoms of viral upper respiratory infection, and the virus, when settles in the lower respiratory tract in the bronchiole, it causes inflammation and leads to bronchiolitis. Bronchiolitis is a viral lower respiratory tract infection in infants and very young children, 2 months to 2 years of age, with peak 2 to 6 months. Incidence is markedly increased with seasonal peak between November to March. So this is a disease of winter season. Pathologically, there is bronchiolar obstruction caused by edema, mucus, and cellular debris, leading to overinflation, atelectasis, and impaired gas exchange. So what are the etiological agents? As I previously told, it is a viral infection, and respiratory syncytial virus is responsible for more than 50% of cases. Among the other viral causes, there are metapneumovirus, rhinovirus, parainfluenza, influenza, bocavirus, and adenovirus. There are several risk factors for developing bronchiolitis, which includes prematurity, low socioeconomic condition, crowded environment, non-breastfed infant, because we know that breastfeeding provides IgA, which has some protective role against bronchiolitis. Exposure to passive smoking and indoor air pollution. So when the respiratory syncytial virus, it settles in the lower respiratory tract, it is engulfed by the alveolar macrophages and it releases cytokines, causing airway inflammation. And again, the respiratory syncytial virus, it disturbs the epithelial barrier and causing a release of chemokines. Also, altogether, these two effects leads to airway inflammation. This airway inflammation leads to airway edema and increased mucus production. And the epithelial barrier, because it is disrupted, then there is sloughing of the epithelial cells, cell death and sloughing of the epithelial cells, altogether leads to narrowed airway and increased airway resistance. All these factors leads to wheezing, atelectasis, and hyperinflation. This is a diagram which shows the time period of symptoms and pathophysiology. So initial 0 to 3 days, 2 to 3 days, the virus is in the upper respiratory tract. So it causes rhinorrhea with or without fever. After that, the virus settles into the lower respiratory tract, and there is further epithelial infection with edema, sloughing of the cells into airway, mucus production, and the epithelial ciliary function is impaired. In this situation, there is the persistent cough, increased work of breathing, and respiratory distress. And this respiratory distress causes impaired feeding. These things happens after 2 to 3 days. And after 7 to 10 days, the patient gradually improves in most of the cases, but sometimes if there is some other comorbid condition, then there may be some other complications. That means patient may develop other secondary infection like otitis media, pneumonia, or other complications. And here is the cross-section of the normal bronchial lumen, and it is the inflamed bronchial lumen. You see there is marked reduction of the lumen. The pathophysiology of acute bronchiolitis is characterized by bronchial obstruction with edema, mucus, and cellular debris. So the edema, mucus, and cellular debris, it causes bronchial obstruction, which leads to expiratory wheeze, air trapping, and lung hyperinflation. The bronchial obstruction, it causes the resistance of small air passages, and it is increased during both inspiration and expiration phase. But because the radius of an airway is smaller during the expiration, the resultant respiratory obstruction is more during the expiration. That's why we get only expiratory wheezes. If the obstruction becomes complete, here you see when the obstruction is complete, then air can pass during the inspiration phase, and then it cannot move out because during expiration there is more narrowing of the airway lumen. So there is air trapping. When the trapped air is get absorbed, then there is development of atelectasis. Hypoxemia is a consequence of ventilation perfusion mismatch, and with severe obstructive disease, hypercapnia can also develop. The clinical findings observed in bronchiolitis include tachypnea, expiratory wheezing, crackles, rhonchi, increased work of breathing, that is flaring of the alanasi, head nodding, use of accessory muscles or of respiration, chest indrawing, and cyanosis in severe cases. So if we see, look at the clinical features in history, there is usually the initial episode of upper respiratory cataract followed by cough, respiratory distress, and wheeze. Fever may be associated with usually of low grade, and feeding may be impaired in severe cases if there is much respiratory distress. Clinical examination. In inspection, we can see the fast breathing, increased work of breathing, and cyanosis and apnea in severe cases. Percussion note is hyperresonant because of air trapping. And auscultation, we get breath sound is vesicular with prolonged expiration, widespread rhonchi over the both lung field, and there may be fine crackles, especially if atelectasis develops. Now, the points to remember. Complete obstruction to airflow can eliminate the turbulence that causes wheezing. Thus, the lack of audible wheezing is not reassuring. আমরা যদি একটা বাচ্চার হুইজ পাচ্ছি না, কিন্তু বাচ্চাটার অন্যান্য যদি রেসপিরেটরি ডিস্ট্রেসের সাইন থাকে, তাহলে পারে কিন্তু আমাদের অবশ্যই মনে করতে হবে যে বাচ্চাটা গ্রেভ সিচুয়েশনে আছে। আমাদের এতে খুশি হওয়ার কিছু নেই যে হুইজ পাচ্ছি না, ঠিক আছে, বাচ্চা ভালো। And poorly audible breath sounds also suggest severe disease with nearly complete bronchial obstruction. Now, what are the investigations? Bronchiolitis is mostly a clinical diagnosis. Usually no investigation is required, but we can take the nasopharyngeal aspirate. Sometimes it is done for some research purpose or to identify the etiological factors. But every patient should undergo a pulse oximetry. We have to know the oxygen saturation level of all the babies suffering from bronchiolitis. Chest radiography usually not done routinely, but until unless we suspect some other diagnosis. And blood tests are not routinely required until unless we suspect other associated infection. But blood gases may be useful if in severe cases, if there is advanced respiratory support is needed. If we do the chest X-ray in bronchiolitis, sometimes we need to do because we cannot rule out a possibility of pneumonia in the child. Sometimes the symptoms are very much overlapping or confusing. So in those rare cases, we do some X-ray, chest X-ray. And in chest X-ray of bronchiolitis, we see the features of hyperinflation that is marked by the low flat diaphragm, and there is the horizontal ribs, and also there is hypertranslucency. Now, this slide is for mostly the undergrad or fifth year medical students, because this is one of the common question that is asked during the viva, or that is given in the short question as a short question. So what are the how to differentiate bronchiolitis from pneumonia and asthma? So bronchiolitis is mostly a disease of infants. It is more common in below 2 years of age, and the peak is 2 to 6 months. Pneumonia can occur at any age, and asthma, yesterday we knew that it is mostly occurring more than 2 years of age. Runny nose is present in bronchiolitis, pneumonia usually absent, and asthma, it may be present. Wheeze more marked in bronchiolitis and asthma, and in pneumonia, usually wheeze is absent until unless there is severe inflammation or other associated chronic lung disease. Fever is of low grade in bronchiolitis. In pneumonia, it is moderate to high, and asthma, usually fever is absent until illness is associated or triggered by any infection. Crackles is usually not present in bronchiolitis, but sometimes fine crackles may be present, especially if the patient develops atelectasis. In pneumonia, there is marked crackles, and asthma, crackles is absent. Rhonchi is more marked in bronchiolitis and asthma, and in pneumonia, it is again usually absent. If present, then it's mild. Response to bronchodilator. In bronchiolitis, usually there is no response to bronchodilator. Pneumonia, no response, and in asthma, it's good response. We know in asthma there is a reversibility of the airway obstruction to bronchodilator, and this is one of the diagnostic tests. And WBC count in bronchiolitis, as this is a viral infection, it is usually normal. Pneumonia, there is neutrophilic leukocytosis, and asthma, usually normal, but there may be eosinophilia. And chest X-ray, there is hypertranslucency and hyperinflation in case of bronchiolitis. In pneumonia, there is features of consolidation or patchy opacities, and in asthma, there is features of hyperinflation. Now come to the management. Management of bronchiolitis is mostly supportive. In mild cases, home care is enough, and we need to teach the mother about the home care, mother or the caregiver about the home care. That is head up position, continue normal feeding, and the mother should give frequent small feed, and if the child is breastfed, then frequent breastfeeding is advised. Cleaning of the nose with normal saline before feeding will ease feeding. Close monitoring of the condition. And we have to tell the mother about the danger signs, and we have to tell them to look for the danger signs. And if those are present or the child's condition is deteriorating, then she or he need to come back to the hospital. And in severe cases, the patient should be managed in hospital. So what are the admission criteria for hospital management? The following features should prompt consideration of admission: oxygen saturation less than 94% in room air, respiratory rate more than 70 per minute, marked recession, respiratory distress, grunting respirations, and history of apnea, taking less than 50% of the usual feeds. Concerning hydration status, if the baby is not taking adequate fluid and shows features of dehydration, then the baby need to be admitted immediately. If the baby is lethargic or appears unwell, and the duration of illness is also a relevant factor, because the peak of the illness of bronchiolitis is typically at 4 to 5 days. Therefore, if the one patient comes at the end of 4th or 5th days, and the baby is still okay, not very much, not showing any severe signs, then we can send back the baby to home care. But if the baby comes with some grave condition, then we need to admit immediately. So who are the high-risk infants? The following have increased risk of severe illness and should have lower admission threshold. that is younger age, if the baby is around 2 months old, or even less than 2 months old, showing all the features of bronchiolitis, then we need to admit the child even at low threshold, because in case of young children, the mother may not recognize the features of deterioration. If the baby is an ex-preterm baby, because in ex-preemies, the lung function may be impaired. If the baby is suffering from any chronic lung disease, if the baby has any other congenital heart disease, if the baby is suffering from any neurologic disorder, if there is any immunodeficiency disorder, if trisomy 21 or other syndromic association, then all these infants are high-risk infants, and we need to admit them into the hospital, even though they're not showing the danger signs. Now, what is the hospital management? We need to, the two main stem of management is maintaining adequate oxygen saturation. It is the most important part of the management, and another one is maintenance of fluid and nutrition. So if we consider the oxygen level, the supplemental oxygen should be initiated for oxygen saturation 90% or below. And we should aim to keep oxygen saturation more than 92%. Oxygen can be administered via a number of delivery devices like humidified head box oxygen, humidified facial mask oxygen, and high flow nasal cannula. So this is the head box. And here oxygen is delivered by the face mask. It is quite similar to the nebulizer machine. And this is the high flow nasal cannula. This one is the best. But unfortunately, in our setting, especially in the peripheral hospitals, we don't have none of these available. As we have the face mask, of course, but many of our hospitals don't have the head box or the high flow nasal cannula. In those cases, we should give whatever is available, but we need to give some form of oxygen. Now come to the fluid and nutrition. Nasogastric feeds, if the baby can take orally, then oral feeding should be continued. But if the baby is taking less than 50% of the requirement, or the respiratory rate is more than 60, or the baby is in supplemental oxygen, then nasogastric feeds should be started. Intravenous fluids should be reserved for severe illness with severe respiratory distress or when nasogastric feeds are not well tolerated. Fluid restriction to 70 to 80% of maintenance due to possible SIAD with RSV infection. And care should be taken to use the isotonic fluids due to risk of SIAD-associated hyponatremia. And other measures, as in home care, that is frequent suctioning of nasal and oral secretions to relieve the distress and improve, and this relief of distress will improve the work of breathing and ability to feed. So what about the role of antiviral? Previously, one antiviral, that is ribavirin, was used in case of selective cases, but although ribavirin is the antiviral medication targeting respiratory syncytial virus, it's not currently recommended anymore because there in the studies it has shown minimal impact on the disease outcomes, and moreover ribavirin is costly and is difficult to administer, and it is associated with important toxicities. Now, this is one of the questions that is commonly asked in the viva voce examination, if there is any long case or short case in bronchiolitis, and regarding the management, what is the role of antibiotics and steroids? So antibiotics usually not required unless there is definite evidence of secondary bacterial infection. and steroid, nebulized salbutamol, nebulized epinephrine, and nebulized hypertonic saline. Although several studies has been done, but in meta-analysis, these have shown no proven benefits. Now come to the prognosis. So majority of the patients improves without any complications. The median duration of symptoms in ambulatory patients is approximately 14 days, and 10% may be symptomatic for 3 weeks. The case fatality rate is less than 1%, and even though even though who dies are in those cases, the majority of deaths occur due to bronchiolitis associated with other comorbid conditions like bronchopulmonary dysplasia, congenital heart disease, or immunodeficiency disorder. Now we have to give some advice to the parents or counseling. We need to tell that because in the previous slide we have seen that majority of the cases the patient may have, although they recover spontaneously, but they may have symptoms lasting up to 3 weeks. So we have to tell the parents that cough may persist for 2 to 4 weeks. So no need to worry, it will go away. There may be an increased chance of wheezy episodes in the future, especially if there is family history of asthma or other reactive airway disease. And this is very important. The third point is avoidance of cigarette smoke exposure. If any of the parents is smoking or anyone in the family member is smoking, then we need to tell them that smoke exposure is an important risk factor for developing or recurrence of bronchiolitis. So we need to minimize. Now, how to prevent bronchiolitis? Because this is an airborne and droplet infection, so meticulous hand hygiene is the single most important measure to prevent transmission of the virus responsible for bronchiolitis. And this is some advanced current medications for high-risk populations. In the West, they use palivizumab, and this is an intramuscular monoclonal antibody to RSV F protein, and it may be given as a prophylactic agent. But currently, so far I know, it's not available. Palivizumab is not available in our country yet. It's not used in our country. But we need to know if as there's some recent advancement. So palivizumab has been demonstrated to reduce the risk of hospitalization to RSV bronchiolitis in certain populations. So that's all about acute bronchiolitis, and thank you all. Thank you very much.
Thank you, madam.